So my name is Matthew Ellinwood. I'm the Chief Scientific Officer here at the National MPS Society. This is a relatively new position at the Society. I was the first CSO and I started a year and 10 months ago. But the Society has had a long program supporting science and research almost for the entirety of their existence, which goes back to 1974. They've had a scientific advisory board to help guide research, et cetera. And I've been a member of that board before I came on. And we also have a very active external grants program. So last year we supported over $1 million worth of external funding in grants from the Society. So that's our sort of role in promoting science and my role here. Overall, the Society's mission is to cure, advocate, and support families and patients with MPS and ML disorders. It's an exciting time. There have never been more approved therapies and more therapies on the horizon, but we are also mindful that it is sobering in that there are still syndromes for which there are no approved therapies and no clear-cut path to screening programs, et cetera. So it's definitely glass half full, glass half empty type of status for us as an organization. Lots to do, but lots to feel like we've accomplished as well. Much of it depends on their insurance status and where they live as a state. Because we have a newborn screening program in the United States that is a federal system and run by individual states. Programs may be quite diverse. And honestly, we only have one condition that is completely certified at the federal level as a recommended condition to screen for, that's MPS 1. At the federal level, though, we're hopeful that by July 15th, MPS 2 will be officially listed as well. But the implementation of those recommended listings is up to states. And that varies as to the wealth of a state, the population, how easy it is for them to add conditions, et cetera. So MPS 1, which was approved at the federal level as a listed recommended condition in 2016, only now 3/4 of the population in the US is or is soon expected to be screened for in terms of new births. So it is a patchwork program, as it were, for diagnosis. We are trying to improve it. We are very much focused on the Society on making sure every condition gets a nomination and fulfills the criteria for being nominated. And once nominated, that we do as much as we can to make sure states start testing. So there's no real easy one-stop shop to fix this problem. It takes a lot of grease and elbow grease, as it were, to push on levers at the federal and at the state level. So that's diagnosis. And therapy, a lot of that depends on insurance access in terms of speed, with which patients get started on therapy. I don't know, however, that we've ever had problems where patients are not able to get therapy for one of the approved therapeutics, which include MPS 1, 2, 4A, 6, and 7. There may be a difficulty in terms of the speed with which they're approved, but I've not heard of problems of them actually getting therapy. There may be issues in terms of finding out where they're going to get a transplant if it's an MPS 1 severe case at the right age. But I've, again, not heard of cases where that has not happened. There may be issues where states will direct patients only to certain programs. It's still an open question whether that's optimal or whether it would be better to have set centers of excellence and have some mechanism where all those patients are seen. In our system, one of the concerns is that if a family doesn't have insurance or enough insurance to take care of a patient like a Hurler patient who needs a transplant, some states require they be in state, and those states may not have as much experience. So overall, I think there's good access, but there may be situations in very clearly defined circumstances where it's not ideal, but these are on our radar, and we do try to help in every way possible to facilitate optimal treatment for all the patients we learn about. Our three objectives are to cure, support, and advocate for families. And that story is, those three objectives are always paramount to us. In the areas of support and advocate, we have a lot of different programs, and much of it depends on what a family's needs are. And of course, as you know, there are MPS patients who have attenuated disease that does not involve cognition and does not involve a drastically shortened lifespan. And then we have diseases such as Sanfilippo, where it's quite different. So there's a variety of patients that we need to be thinking about. We have direct support programs for families. We have programs to help families identify optimal educational pathways. So individual education plans, which is something that we have to help our families develop so that they can make sure that their child has adequate educational support for their special concerns and needs. So those are the sorts of programs that we're involved in terms of family support. When it comes to multidisciplinary management and care, most of our patients will be seeing multiple types of clinicians or support: occupational therapists, speech therapists, physical therapists, all of these sorts of initiatives. For the young person, a really nice outline for these sorts of efforts was encompassed by a publication that came out during COVID, and it was really directed on preserving and defining optimal educational support for individuals with neurocognitive MPS in contexts of an educational environment. But this publication also details really nicely what a multidisciplinary support would entail for these sorts of patients as well. So I think many clinics have grown up organically as centers of excellence based on the early offerings of therapeutic modalities, or just simply because they were some of the most well-known clinicians in the field. And I think about the University of Minnesota and their pioneering work for bone marrow transplantation. As a consequence of that early work going back to the 80s, they have become, as it were, a center for working with MPS patients. And I think that continues now as an unofficial center of excellence for MPS, because they just have that long history. And even MPSs where they're not offering bone marrow transplantation necessarily, they have long experience understanding that you need to have audiologists, you need to have speech therapists, you need to have psychologists, you need to have neuroradiologists. And so they get it, because they just have been working with these syndromes for, gosh, now 4 decades. Similar program right here, actually, at University of North Carolina, associated with Dr. Joe Munzer. And these are just programs that have a lot of deep history, so to speak. There are other areas where clinicians are just so knowledgeable about these disorders that they understand the multidisciplinary need. For our Morchio community, a lot of that community will gravitate towards Nemours Hospital, William Mackenzie, and clinicians and researchers there. There may be other areas where, we have clinicians who have a long history with these disorders, and they create a network, and these things evolve organically. There is a new program here in the United States that is identified through our National Organization of Rare Diseases in collaboration, I think, with the division of the NIH, and they highlighted rare disease centers of excellence. This is a distinction for those centers. I don't think there's any money that comes with it, but as I look at the names of those centers, many of them have clinicians we know who are associated with MPS, who have a history of working with MPS. And hopefully in the future, we'll be able to develop that network as an informal network that can help optimize MPS approaches to therapy from an interdisciplinary and interinstitutional framework. But right now, that's just a network. It was just established in the last year or two. So, but that's a potential future avenue, so to speak. Because another thing is, as we get more of these patients diagnosed through newborn screening across the country, there's going to be they're going to be in more far-flung places. And I'm not sure that as we develop a more routine approach towards diagnostics and treatment, it really makes sense in the future to relocate all these people, or for all these people to be relocated. And I think one of the benefits coming out of COVID is we've learned that telemedicine can do a lot, and networking with individuals who are knowledgeable and leaders in the field can do a lot. And we're seeing some of that even with neurocognitive assessments. So we have a grant that has been awarded to Julie Eisengart's fellow Brianna Young, where she is working on a distance neurocognitive assessment for patients who are not usually thought of as having a neurocognitive impairment. So MPS 4A, 6, attenuated 1 and 2 patients, and attenuated 7 patients. And the idea is there, even if they are intellectually intact individuals, and they may still have concerns about the ability to focus, the ability to marshal short-term memory and such. So we're doing a at-distance, or we are supporting, I should say, an at-distance study to help evaluate those things. So I'm hopeful, again, as newborn screening becomes more widely implemented and we're finding patients earlier in more diverse locations, we'll be able to manage these things so that not everybody has to come to one center in the country type situation. I think it is a very exciting time, and especially an exciting time for MPS II. So we have 2 drugs that have either been approved or are in clinical trial that are enzyme replacement therapy-based drugs that are designed to cross the blood-brain barrier. One of those compounds is developed by Denali, and that is in clinical trial. Another compound, which has been developed by JCR, is approved in Japan, but it is also being developed for approval through clinical trial in the rest of the world, and that's also for Hunter. And they both cross the blood-brain barrier. They're different mechanisms, but a similar idea. Those are incredibly exciting developments. To think that there is an enzyme replacement therapy that you could potentially begin shortly after diagnosis, after birth, that could cross the blood-brain barrier, that is a game changer. So that's incredibly exciting. There are also current clinical trials with intrathecal administration of AAV vectors. REGENXBio has that program. There is also a new company, Homology Medicine, that has a group of new AAV vectors that can be administered intravenously and are extremely efficient at crossing the blood-brain barrier. So that could be another approach to an AAV vector treatment for Hunter. So some very, very exciting programs there. Homology Medicine does not yet have a clinical trial, but they clearly have a stake in the ground for Hunter and are developing a product and are developing the infrastructure for a clinical trial. There's also a very exciting approach to treating lysosomal storage diseases that has recently been validated within a clinical trial, and I'm hopeful to see that extended to other MPS disorders. And what I'm talking about is a combined ex vivo autologous lentiviral-based gene therapy and transplant. So that's a long description, but what happens is you mobilize stem cells from a patient's blood, you get those stem cells out, in vitro, you treat them with a gene therapy vector, you do some quality control on those cells that have been treated, they then become the drug, and you infuse it back into the patient who has had a mild, non-ablative chemotherapy treatment to create room in the bone marrow. I don't think they're actually, it's not like you have to evict some apartment tenants so that you can move in more bone marrow, but it does help with the engraftment. And that report, that trial, which is based in Milan and Manchester, has just reported on their first group of patients. They were MPS I Hurler patients who did not have transplants available to them. And they were treated on an average of the age of 2, and the study was based on 2-year follow-up. Those results are incredibly exciting. And of course, in MPS I, we have a standard of care in the severe patients, which is bone marrow transplant. And I think if this particular approach shows improved benefit compared to just regular transplant, it could be a really attractive avenue for both brain affecting MPSs as well as bone affecting MPSs. So this could be a really exciting approach that could be extended to other disorders. And the attractiveness is you don't need a match. You are your own donor. You don't have graft versus host disease because you are your own donor. And you don't have a ablative bone marrow conditioning to survive because it's a non-ablative chemotherapeutic treatment. Interestingly, in all of the patients with MPS I who had been treated with enzyme and who had developed anti-drug antibodies, within a short time after their gene therapy and transplant, those antibodies disappeared. So there was something that about the treatment and the replacement of stem cells that had been transduced with the enzyme cDNA that tolerized them immediately almost. So lots of exciting movement in terms of therapeutics for the MPS disorders. Other areas involve symptomatic treatment. So you may know about Paradigm Therapeutics, which is a company that is trialing a osteoarthritis medication, pentosan polysulfate, for treatment in MPS. And it's really focused as a treatment for pain. And that has been evaluated in a research setting on animal models for some time now. And interestingly, it shows not only efficacy for pain, but also storage and central nervous system disease. So there are symptomatic treatments like pentosan polysulfate that are being developed that could increase our arsenal for not just attacking the root cause of the disease, but addressing practically some of the other aspects of the condition as well. So we do not have one single MPS registry. There have been some registries that are historical, some registries that are associated with natural history studies. The Society has partnered with 2 other MPS organizations and started a registry. It is not necessarily complete or comprehensive. It has patient-reported outcomes. But again, it's not necessarily, it's called Connect MPS, and it's not necessarily comprehensive in that regard. And some other MPS societies or organizations have gone with syndrome-specific efforts to develop patient-recorded outcome registries of sorts. So I believe San Filippo is working with a group called All Stripes. I believe maybe Morchio is also working with All Stripes. But these are not necessarily registries that incorporate medical data or exams, etc. More, they may be personally maintained by patients, have patient-reported outcomes, things of these sorts. Ideally, in a perfect world, we would have a data set that incorporates historical natural history studies, clinical trial data, patient records, patient-reported outcomes, and be controlled by patients so that they could opt in or opt out, and that information would be universally available to researchers and entities trying to develop therapeutics. The big hurdles to those sorts of universal access of data involve how you manage what I'll call heritage data sets, previous studies, clinical trials, etc. And there are issues around consenting those trial data, and they may not be freely available. And then the other concern is they're all in some kind of data platform. And from a data science standpoint, they may not use the same terms, or even if they use the same terms, they don't collect data the same way. So federating this data or uniting it is, at this point, a dream. The society realizes this is an important issue. And then, of course, we're trying to think globally about how could we set up a platform for the entire world, because when you're very rare, numbers help you. And so how do we set this up that it may be consistent with growth that could incorporate international data sets as well? So we're thinking about these things and we recognize they're important. We don't have a set program at this point. We do have, and something that has been supported by the NIH, something called the Lysosomal Disease Network. And this was an NIH program that was funded based at the University of Minnesota. And they have a observational clinical database, maintained, consented, governed by institutional review boards, et cetera. And that is focused on all of the MPSs. But that's a small subset of clinicians. It may prove a good framework within which to grow this, but early days still. But that's the largest network of information I know of clinical data for MPS patients. Well, my message to all of you would be to find community among your fellow travelers in the MPS space and do what you can to expand that community. I think, especially in these times of pandemic, where some of us have been feeling at risk and isolated, what really brings benefit to all of us in every way is to find community with our friends, with our families, with our broader associations, to find fellowship there, support, and gratitude. And I think keeping your eye on the ideas of community and support and gratitude and education is always an uplifting effort. So I would enjoin you all to think about that as a big message to get you through MPS, International MPS Awareness Day. It's been great to visit with you, and happy International NPS Awareness Day to all of you in Brazil.